Okay, wanted to go over a little presentation today with you guys on swing bed and skilled care. Just thought it'd be nice just to give you a little refresher, especially for those that are just hired. Little history about swing bed. It's been a vital part of our rural healthcare delivery for over 40 years. Dr. Bruce Walter was the one that basically put it into practice in the late 70s and 80s. Acute care needs in rural healthcare systems were really difficult, and so I think this made it more available for those that were in rural America to kind of have that opportunity. Swing bed program allowed rural and critical access hospitals to serve patients by keeping them in their own communities. A little bit more on swing bed. The swing bed programs are allowed in hospitals with less than 100 licensed beds. At Community Healthcare System, we are a 25-bed critical access hospital, so therefore we qualify. Swing bed allows them to use their beds as swing and or acute, depending upon what the patient is there for and if they qualify for swing bed. Again, the reimbursement for both are different. Swing bed is also considered to be a skilled level of care where they're requiring additional services that are skilled. Authorization is based on week to week, and we really want to focus everything on patient-centered goals. So what the patient wants, what their desires are, how we can meet their needs. Traditional Medicare requirements of swing bed, you have to have a 3 consecutive midnight stay. That means they can't be in an outpatient bed. They have to be an acute patient for 3 midnights in order to qualify for the swing bed program. Medicare Advantage do not require that, but they may have to be offed where they have to have insurance that says, yes, you qualify for this. And again, patients must have at least one daily skill that's necessary and reasonable. So something that's whether it to be getting stronger, they're not safe to go home, or they have IVs, or they need a certain injection, those things would meet those needs. Again, we talked about Medicare. That's the primary insurance plan. The Part A portion of that is what covers the swing bed stay. There's 100 days that people can qualify for if they do meet those needs for that duration of time. Again, if they are not making progress, those days could be cut short. The first 20 of those days are paid at 100%, and the secondary 80 days are only at 80% coverage, but then typically if you have a secondary, it should help cover that additional cost, and or there may be a co-insurance or a co-payment. So just so you know, and then after that 100-day, there has to be a 60-day spell of wellness without them being admitted into an acute care setting to then qualify for an additional 100 days. Critical access hospitals are reimbursed at 101% of those Medicare costs, and it's an all-inclusive rate, so you get a 1 daily payment for everything that's included. That would be your room and board, nursing costs, therapy, medications, labs, radiology, and any other procedures that they would need while they're here. So again, it can get kind of costly. So when people say, oh, you get this much money, well, it includes everything. And that's your labor of your care staff that's taking care of them. That is just a whole gamut of things that it could be. Skilled care, who does that? So basically it's your therapists, it's your nurses, it's your aides, it's your providers, it's your radiology techs, but really truly the instrumental portion of that comes from your nursing staff, those people that are getting out there every day and that are doing that daily check on the patient 7 days a week. As for the skilled rehab portion, you can have your speech therapist or your physical therapist or occupational therapists that are out there working in a combination of 5 to 7 days, whatever the patient really needs. Sometimes it's once a day, sometimes it's twice a day that therapy is going in there. And as for nursing, it's a constant daily check on that patient to see where they're at to meet their needs. Skilled services that we do on a daily basis would be that nursing care, that helping them to the bathroom, getting them dressed, getting them more independent. Other skilled care needs would be injections, wound care if they have a wound, education and training if they're a new diabetic, if they have a new colostomy, if there are new medications that they don't know how to take on their own and they live alone. Additionally, if they have congestive heart failure and they need monitoring of weight and blood pressures, those would be the things that you would start to see. Why do swing bed? Why? It makes the patient feel cared for. They get to stay close to home. They get enhanced services that they wouldn't get anywhere else, where they have, meals that are provided for them while they're recovering from something that could have been a surgical or just a hospital stay that was lengthy that took a lot out of them. It's continuity of services where they can stay in the same place that they actually had their procedure, and they can stay in the rural area or in the community. Other skilled services to note, or other things to note about skilled services, it does require that a provider has written that order for them to be on swing bed. Additionally, it requires skilled therapists or skilled nursing, and it requires those enhanced capabilities. And then a combination of those disciplines, making sure the patient doesn't get overwhelmed and making sure that we give that highest level of patient care possible. We want to, within that rehab plan, we want to make sure, again, that those goals are reasonable and that they are patient-centered. And it's what the patient's saying. Hey, I need to be able to get in my house because I need to do this, this, and this. And I have this many stairs. And those adaptations that we can help with before they go home is essential. The complexity of the patient does play a big role in that, as well as the expectation of what the patient wants to meet before they go home helps to enhance that service. And we really focus on that prior level. Where were they at before? And was that the highest practical level, or is that just the prior level? Because sometimes people are they've become pretty deteriorated by the time that we see them in the hospital. And then somebody says, well, they were doing that at home. Well, they really weren't strong enough at home either. So we want to make sure that we get them to a place that they are safest and strongest. Things in this slide will tell you everything that physical therapy really does focus on. That strength is key. If they don't have the strength to do certain things, they're not going to be able to do it. Some things people may not know that we really, really work on: prosthetic fitting and training for amputees, orthotics, if they need a lift or a shoe lift, pelvic floor therapy. Caregiver education is huge. Endurance, core strength, if they've had a joint replacement, range of motion, simple things, but yet it's good to review. Occupational therapy, the next two slides, because this is a big place of fine motor skills where it's the intricacies of putting a button or tying a shoe. Some of those things are really important, and so that's where OT comes in. It's dressing, it's bathing, it's grooming, it's ensuring that they can get dressed in endurance and energy conservation in order to do so without fatigability so that they're not falling. They also do driving assessments. They help keep them busy with their independent activities. If they need to go to the grocery store, can they do that? A lot of those things that you can see listed here. Additionally, these are other areas that we work on. If they need adaptive equipment, a reacher or a sock aid that helps you get your sock on a shoe horn. So they would help determine the needs. And sometimes we have patients that have really bad tremors or shaking, and so we may need to use weighted utensils, or we may need to use a guarded plate, something that helps them scoop up the food if they have certain ailments or diagnoses. Speech therapy is an integral discipline that really focuses on a multitude of things, whether it be cognition, it could be swallow, or it could be speech, with the ability to help with articulation. Cognition, we deal with a lot of patients that have to remember how to get out of a chair. We have to have them be able to remember, oh, how do I turn the stove on, turn it off, so I'm not going to light my house on fire. These therapists really get in there and they decide, do they have memory deficit? Do they not? Can they retain that short term? Can they not? And then how do we give them teaching strategies in order to fulfill that void? And then the same thing with swallow. If they are having certain diagnoses that could cause, that weakness, and weakness does happen as you age in general, but just being able to increase the muscles that allow for swallow is essential, and there are exercises that they walk them through in order to do that. If we need to upgrade or downgrade diets, if we need to do a study that can show all of that, we can do those too within our hospital setting. So they work with the nursing staff and the dietary staff in order to make sure that we meet their needs nutritionally, as well as that they're safely eating and drinking. That voice and quality, patients with Parkinson's, patients that have, certain other diagnoses may have a difficulty with phonation or getting out the volume that they need in order to be heard. And then also articulation, or just being able to comprehend what somebody's saying, or being able to articulate what you're thinking. That expressive and that expressive aphasia that sometimes people say, I'm trying to say this, but I can't say this. So that's receptive, as well as when you're unable to kind of get that back in. So just know they work on that, as well as the other things that you're seeing here. Levels of assistance. The language between what therapy is saying and nursing saying sometimes doesn't coincide. So we included this slide so you can kind of see how we term things with patients. If I'm just standing by them, it's pretty simple. I'm standing by them. Supervision means they're down the hallway and I can still watch them, or I'm in the front of their doorway and I can say, okay, get up and get around. That's supervision. Modified independent means they have a walking aid or they're holding onto a rail, but it's though they're independent, but they may need additional setup, or they may need a walker or a cane to help them, but they're able to do it on their own with that device, whether it be an orthotic or, like I said, a cane. Those would be the reasons for that. Independent means they need nothing. No device, no help, no anything. They're good on their own. And then you see the other ones on here. It's more about min, mod, max. It's the percent that I'm doing to help them. So if I'm doing 25% of the work and they're doing the rest, that's min. And then upscale to kind of see how we get to a max, or a dependent, which I'm doing all the work, which we don't want. But that's sometimes where we start. Again, goals. For balance, you might want to say, okay, where are they at? And you can kind of see the poor to the good. And that's, again, dependent on how much help I'm giving them to maintain their balance. And that could be static or dynamic. Static being standing or sitting and not moving, or dynamic, moving within that plane, whether it be walking or sitting. Again, level of assistance in the rooms and things that we're going to do to outline kind of where they're at, being red, yellow, green, blue, and if they are high risk, how to identify that they're a high risk for falls. And then again, things that we're going to put on that whitey board, you'll see to the left, oh, these are how much they need help in the room. Here's what we're working on in rehab. We may have a cane in the room, but we're not ready for them to use it with you. We want them to use a walker. Those are things that you'll note. But if they're independent in their room, these are the things we would expect. You know what I'm saying? They have to be at a certain level. Mobility and transfers, again, that's more adaptive equipment, what we would need to use with them in certain areas. So walker, cane, wheelchair, lift. If they have to have a wheelchair follow, do they need oxygen? Do they sock gauge, shoehorn, reacher, all of those things. And then in the bathroom and showering, those are the things we're looking for to make sure, can they go home safely? And do they need those adaptations there? Again, functional areas, those are all the things people sometimes forget. Oh, golly, can they manage their oxygen tubing when they get home? Are they going to trip on it? Stairs, curbs especially, if they have to go out to get the mail. They're having to go up and down that one step, and it can just be enough to throw them over the edge. Car transfers and even cooking. If they're their primary person in their home that does all that, I mean, they're going to have to get back to being able to use the microwave and the stove and get the stuff out of the fridge with a walker. And where am I going to put it? So things to remember. Functional goals. It's the ABCDs. It's what are they doing? Who's doing it? What's the condition? And then for how long? So we need to set goals that are based on what the patient wants, and we need to identify, what do they have to do to be safe? Especially if it's all their plates are way up here and they can't reach them anymore because they had a shoulder surgery. We need to get everything at a certain height. So those would be good goals, and those that are listed on this slide you can see. Good questions to ask. Meals, who's doing that? If you have an outing, who's taking you? Are you really safe at home? And do you have anybody else coming in checking on you? Do you have a life alert? What's your phone situation? Do you have Wi-Fi? If you have caregivers or private caregivers, when do they come? What modifications do you need? Do you have somebody to help with those? Those type of things are important to ask and start getting that feedback. We do home assessments, especially if they're close. If they're further away, it's kind of one of those questions whether or not it's too far away from the hospital to do. But a good thing we do assess on patients is, how many levels do they have to go up or down? Are there stairs? Is there a driveway? Are they parking in the garage? Are they parking outside? Which door are they entering? Is it the front or the back? Do they have pets? Do they have to be able to get them outside? Do they have to bend over to attach their leash to them? The laundry room, how is it set up? Are you doing laundry? And again, you can see the multitude of things that we go through with a patient on a home visit. But again, it's setting those goals to get the patient home and home safely on day one. Home assessment, additionally, things we look at, rugs. People don't want to pick them up. But again, we're not telling them it's a recommendation. We don't want the rug there. I have before kind of set it up like, oh, let's try it without the rug. And just to see if they are willing. But again, sometimes you'll show up there and it's back on the floor. It's their home. We're not going to alter or change it, but we do make recommendations based on that. We sometimes will have to take measurements before we go on a home visit. Like, is your walker going to fit through that door? Are you going to have to enter sideways to go through the door with your walker or your cane? If they have a ramp, is it the right level and step heights? And then even down to insects. We've had patients that have had certain bugs and things in the house that we need to make sure that that's safe for them going home. Especially if it's a cluttered environment, it could be a really high fall risk. Things we have them do beforehand. If they need a commode or a shower chair, we get that done. Right whenever they're going home. We put that in there, or the family takes care of it, and then it's there when they're there. Sometimes it's a ramp even that they can't get in the house because they have a wheelchair now. Education for caregivers on what to do, helping setting up meals for the patient. So the first week is a little easier. Grab bars, bed rails, and a lot of things play into that. How old are they? What's their strength really like now? What's their prognosis? Are they looking for a long haul? Are they going to get home health services? What is their weight bearing status? Can they get around safely? And then tolerance, we have had some patients that are non-weight bearing. And so sometimes when there are swing bed patients, we've had to do like a letter of predictability from the provider to allow for an extension of their stay or their days based on that. And so we have done that before just because we don't want them to lose their days under Medicare or under a swing benefit because of, they're unable to make progress based on that. So that's kind of what that is. And you do see some patients as well that just aren't motivated. And you have to either A, be their cheer coach, or B, they're not doing it no matter what you ask. So those all play into part a swing bed. Some abbreviations here that you'll see. I'll lay this slide up for just a few seconds here, but again, you can look through those things that we will put: plan of care, POC, EOB, edge of bed, MMT for manual muscle testing, just the weight bearing. You'll see some of these as we go through. HEP for home exercises. And really the key is knowing your patient, knowing what they are willing to do, what they're willing to fight for, and you're their best advocate. I mean, you want that, and you want continuity of service. You want that same therapist. You want that same nursing staff that really makes the patient feel like they're at home. And you need to know what their goals are and what their intent is in order to make them feel like this is where I should be, and this is why I chose community healthcare system. And again, remember, documentation, if it didn't get documented, it didn't happen. So you need to make sure that you're doing timely documentation, and then you're putting down what you need, because it's going to be essential in getting that visit paid for. And again, we're doing great service and we should be paid for that service. But again, we want the patient to get that, that great clinical skill, but we also have to be able to put it down on paper. And that goes for education stuff. That goes for their home exercise program. That goes for anything that we're talking to them about that would be essential for safety. So just know those are some things that we really want to paint that big picture. Again, try to use words that are here, that um, inhibit, reduced, adapted, monitored. Some of those words are really skillable, and those really show that you are doing what's best for the patient or that you're enhancing their skill set by offering those. Things to avoid: tolerated well. I don't know what that means. That really doesn't mean anything. Observing or supervised. It doesn't really take the technical skills of a therapist or a nurse at that point. So really just painting that big picture. So I just wanted to share those slides with you, and hopefully it gave you just a little bit more insight on what swing bed really is. Thanks so much. Have a great day.